Morning, everybody. It's a great pleasure for me to introduce Francesca da Canal. She will talk today about esophageal cancer. Please enjoy.
Good morning, everybody, and thank you, Professor Guzzo, for your introduction and your help. Today I'm going to speak about esophageal cancer. I will go through definition, type of esophageal cancer and risk factor, incidence and epidemiology, clinical manifestation, diagnosis, therapy, and postoperative complication and prognosis. So esophageal cancer is a cancer that arises in the esophagus and histologically can be divided into squamous cell carcinoma and adenocarcinoma. They represent more than 95% of the esophageal malignancy. So the risk factor depends on the type of esophageal cancer we are talking about. Do you have any idea of some risk factors? They are both a risk factor for squamous cell carcinoma, and moreover, we have HPV infection and beverage consume. The risk factor for the adenocarcinoma, most importantly, include a long history of gastroesophageal reflux disease, male sex, Caucasian race, and age more than 50 years. So obesity and metabolic syndrome, as well as tobacco use and a family history of Barrett's esophagus. So the incidence and mortality trends of the esophageal cancer are changing significantly across the world, with considerable heterogeneity between sex, histological types, ethnic patterns, and geographical distribution. The important thing is that the esophageal cancer is common, with an incidence about 3 to 6 cases per 100,000 people. In about 90% of the cases, it's a squamous cell carcinoma, with the highest incidence rates observed in Eastern Asia and South and Eastern Africa. So in Switzerland, there are about 500 new diagnoses per year, and histological is almost always an adenocarcinoma. Worldwide, the esophageal cancer represents the 7th most common case of cancer death in males. So the scary part of having an esophageal cancer is that the symptoms present very late. So they usually indicate an advanced disease, and that's why it is generally considered a poor prognosis cancer. In fact, at the time of the first diagnosis, about 50% of the patient has already a metastasis. The clinical manifestation can be obstructive symptoms such as solid dysphagia or liquid dysphagia, weight loss, anemia, odynophagia sometimes, and hernias, which is a bad prognosis size because it means that there's an involvement of a recurrent laryngeal nerve, and aspiration pneumonia, for example. The diagnosis of an esophageal cancer should be performed analyzing the local stage as well as the distant disease. It starts with an upper endoscopy to directly visualize the tumor, the localization, length, and take some biopsy. Of course, as greater is the number of biopsies, as higher is the diagnostic accuracy. Is there anyone that can tell me where the tumor is more common?
Well, it depends on the type of the tumor, if it's a squamous cell carcinoma or an adenocarcinoma.
Yeah, most often the squamous cell carcinoma is localized in the upper 2/3, and the adenocell carcinoma originating in the lower segment of the esophagus, most frequently as a consequence of gastroesophageal reflux disease. The second step is the evaluation of the local regional disease with an endoscopic ultrasound. It evaluates the tumor site and the lymph node involvement with a very high sensitivity and specificity. So after these two steps, we can define the tumor's TN staging according to the TNM classification. A T1 tumor is when the cancer is limited at the epithelium and it doesn't reach the basement membrane. T1b is if the cancer is confined to submucosa. In a T2 cancer, that's an invasion of the muscular layer, and if it crosses the entire esophagus, is a T3. Whereas if it invades other neighbor organs, it can be a T4A, if it's attached a resectable organ, or a T4B in case of invasion of unresectable organs, such as aorta, vertebral bodies, or airways. The third and last step in the staging of an esophageal cancer is the investigation of distant metastases. So in Switzerland, we go directly for a PET scan CT because it has a higher sensitivity and specificity in the detection of distant metastases compared to a normal CT scan. And it avoids unnecessary surgery in up to 20% of the cases. The limitation of the PET CT scan are that it has a bad accuracy of local stage and small lesion. That's why it always has to be combined with endoscopic ultrasound. Moreover, in case of squamous cell carcinoma, a laryngoscopy should be performed to assess the local disease and excluded synchronal malignancy of head and neck, as well as a bronchoscopy to evaluate the airway invasion if the cancer is above the carina. So the common metastasis sites are different. For the squamous cell carcinoma, the common metastasis sites are the lungs, whereas for adenocarcinoma, the most important spots are liver, peritoneum, and adrenal glands. As already discussed, we went through the oncological workup in order to stage the tumor and determine their operability. And on the other hand, the patient should undergo to a functional workup in order to evaluate possible contraindication for surgery. These can be absolute or relative depending on their severity. For example, a severe COPD can be an absolute contraindication. Patients that lost more than 20% of their weight over the last 6 months should undergo nutritional GE refeeding, and if they are standing losing weight during the nutritional supplementation, it can be an absolute contraindication as well. So after have a diagnosis, the more important question is, how do we treat this cancer? That is an overview of the therapeutic concepts depending on the different staging of esophageal cancer. So the superficial cancer can be treated with endoscopic resection or surgery. For a T1A cancer, an endoscopical mucosa resection should be performed. The endoscopic procedure has the advantage of a higher quality of life, but it only treats the local tumor without effect on the lymph nodes. That's why there is a higher recurrence rate compared to surgery, so a close follow-up should be performed. For a T1B tumor with a superficial invasion of the submucosal layer, an endoscopic submucosal resection may be an appropriate treatment. If we have a T1B tumor with a deeper submucosal invasion, a surgical resection should be performed. In presence of locally advanced disease, so T2 tumor to T4 tumor, a multimodal therapy should be performed. Both histotypes should undergo a neoadjuvant treatment according to the cross trial, followed by curative surgery and follow-up. In case of adenocarcinoma, a perioperative chemotherapy should also be performed. As demonstrated in the cross trial from 2012, the neoadjuvant chemoradiotherapy has a central role in the treatment of esophageal cancer. The study compares two groups of patients, the first one with 178 patients that underwent a 5 weeks neoadjuvant chemoradiotherapy and surgery. And the second group include 188 patients that only underwent surgery. So this Kaplan-Meier shows very clearly that the patient that undergo a neoadjuvant radiochemotherapy and surgery have a 5-year better survival rate, 47%, compared to the 34% underwent surgery alone. Their R0 resection was even much higher in the pretreated group, 92 against 69%. So a significant reduction of local, regional, and distant progression after neoadjuvant treatment has been shown. The pathological complete response to neoadjuvant treatment was 29%. In a sub-analysis, they show that there is a different response between the two main histological patterns of esophageal cancer. Indeed, there is an improved response in case of squamous cell carcinoma with 49% with respect to the 23% complete response of adenocarcinoma. As such, the indication for surgery in case of clinical complete response after neoadjuvant chemotherapy is being investigated in the Prodigy 32 study, phase 2nd and 3rd, which compares the curative surgeries to surveillance after complete response of locally advanced esophageal cancer to neoadjuvant treatment. So patients with metastatic disease should undergo a palliative treatment with improvement of the quality of life, nutritional feeding, or stent placing in the esophagus. To describe the therapy, first of all, I will explain the surgical approach for the gastroesophageal junction tumor according to the severe classification. So for type 1, a transthoracic en bloc esophagectomy should be performed. Type 3, an extended gastrectomy has to be performed, and type 2 can be assessed for esophagectomy, like type 1, or for an extended gastrectomy, like type 3. So for the esophageal cancer, there is the broad range with broad variation of surgery and surgical technique. The choice of the most appropriate treatment depends on the location of the tumor as well as on the surgeon's experience. The transthoracic esophagectomy has evolved over the years, starting from open transthoracic to the total minimal invasive and the robotic-assisted technique. So for cervical tumor is performed a Mekion esophagectomy with a cervical anastomosis, which is a risicoanastomosis with 3 times higher leakage rate and 5 times higher stricture rate to the thoracic anastomosis. The thoracic esophagectomy is performed in case of lower localized tumor. The most used technique that we even perform here is the Ivor-Lewis esophagectomy, which is a transthoracic technique with an intrathoracic anastomosis and where the esophageal reconstruction is performed with the stomach conduit. The technique has 2 main steps. The first one is abdominal and consists in lymphadenectomy and create the gastric conduit. Once the stomach and celiac lymph nodes are completely mobilized, the left gastric artery and vein are divided except for the the arteria epiploica gastrica dextra. Then we turn the patient and we perform a right thoracoscopy, followed by the mobilization of esophagus, esophagectomy, and lymphadenectomy. And after that all, the gastric conduit that we have prepared in the abdominal part is pulled up into the thorax, and to obtain the continuity is performed a singular stapler anastomosis between the gastric conduit and the remaining part of the esophagus. So a big theme in the comparison between open and minimally invasive surgery for treatment of esophageal cancer. This randomized control trial compared 56 randomized patients that underwent to open surgery with 59 randomized patients that underwent a minimally invasive operation with the endpoint postoperative morbidity. So the minimal invasive technique has a significant lower rate of pulmonary infection and a shorter hospital stay compared to open surgery. The resection margins and the mortality factor are comparable between the 2 techniques. That's why there is a highly acceptance of minimally invasive approach for esophagectomy, and its use is standing increasing worldwide over the years, and shown in this graph from the Haverkamp study. The esophagectomy is an operation with a very high overall morbidity, up to 60%. The main complications are anastomotic leak, up to 30%, anastomotic stricture, up to 12%, and a very high rate of pulmonary complication, 20 to 27%, which is even a higher value than after a major lung resection. It's important to note, as demonstrated in this study from 2004, that there is a significant reduction of mortality and morbidity after esophagectomy performed in a high-volume center. A high postoperative morbidity and a high anastomotic leakage rate have been confirmed also in this study. A multi-center analysis from a cohort of 1,057 total minimally invasive esophagectomy performed over 5 years in 13 high-volume centers. In a spin-off study, has been shown that the occurrence of anastomotic leak reduces significantly the 5 years overall survival after esophagectomy. The perioperative mortality has been excluded. For this reason, in this study, it was investigated if a preventive endoluminal vacuum therapy after esophagectomy could be used in order to reduce the leakage rate and the postoperative morbidity. Perioperative endoluminal vacuum therapy was performed intraoperatively in 90 consecutive patients undergoing minimally invasive esophagectomy. And it has been shown a 0% of mortality after 30 days with a reduction of the anastomotic leakage from 16.1 to 5%. So a preventive endoluminal vacuum therapy appears to be a safe procedure that may have the potential to improve surgical outcomes in patients undergoing esophagectomy. It is currently in progress the pre-sponge trial, a multi-center trial with the aim to compare the preventive endoluminal vacuum therapy to the standard postoperative care in randomized high-risk patients after minimally invasive esophagectomy, with the endpoint on the length of hospital stay, anastomotic leakage, and complication. Coming to the prognosis. Survival is different according to the cancer stage. If the cancer is localized, the 5-year relative survival is 45%. If the regionally lymph nodes and tissue are involved, the survival is around 24%. If we have a distant metastasis, the 5-year survival collapses dramatically at 4.8%. So the take-home message is, if we speak about esophageal cancer in Switzerland, it's almost always an adenocarcinoma. At the diagnosis, nearly 50% of the patients have metastases, where generally a palliative treatment has to be performed. Thus, clinicians are often dealing with an advanced stage incurable cancer in early diagnosis, and that's why the prognosis is quite bad. For localized tumor without lymph node invasion, it can be performed in endoscopic resection. Surgery remains the cornerstone of esophageal cancer, but it is connected with a high procedure-related morbidity and a high complication rate. Surgeon experience and high-volume center plays an important role in the therapy of esophageal cancer. They decrease postoperative morbidity and mortality. So it makes sense to go in a high-volume center to be operated for an esophageal cancer. Thank you for your attention.
Thank you very much. Very, very good presentation. Nice slide. Very good. Maybe my first, I will finish or ask a question on your last comment, for Professor Guccio here. I think the cancer of the esophagus, like cancer of the pancreas, clearly must be done today in a specialized center. for many reasons, just to have the right indication, the right treatment, the experience around you, and now with the robotic and laparoscopic surgery. So my questions, and I think this is still an open question, what is a center of expertise, an expert center for esophagus? Is this a minimal number that we need to be done every year? What would be your criteria to, from the patient perspective? Now you're a patient, you have to decide where to go, where that should be.
So the official perspective in Switzerland right now is that we have 8 centers, and the minimum number of esophagectomies to be performed is 12, which in my opinion is much too low, because if you perform this type of surgery once a month, you cannot really gather enough experience to make this really with low morbidity. So in my opinion, you should at least have 30 esophagectomies per year to develop a reliable standard procedure, and this should be done like this.
Yeah, and one factor also is the resources. You need 2 expert surgeons if you want to cover any time. So with 1 a month is probably difficult. Is there any question, comments?
I think it was an excellent talk. Thank you, Francesca, and quite comprehensive. If there are no other questions, I think you might proceed.
Okay, thank you.
Thank you very much.